Yes, sir, we are live.
We're good to go.
Yeah, ma'am.
All right. Good evening, everyone. Good evening, my listeners. And I, Dr. Swati Bhayana from Fortis Memorial Research Institute, Gurgaon, India, welcome you all once again to this webinar series of innovations in pediatric hematology, oncology, and bone marrow transplant unit. And we have been really blessed to have the companionship and mentorship of very amazing mentors in the field. And I welcome you all to this series of brain tumors that we have been organizing. So, welcome my seniors, my colleagues, and my juniors who have been really flooding my mails and messages and boosting us up to carry on this series and flooding us with their questions. Thank you so much for all the contribution and always looking forward to discussions and mentors with all these amazing speakers that we have. So, in this beautiful month of festival that is going on in India, I take extreme pleasure in inviting Dr. Michael Fisher.
Thank you very much. It's a pleasure to be here. Let me just share
Am I audible? I'm sorry. Am I audible?
Now you are.
Okay, I'm so sorry. I welcome once again Dr. Michael Fisher. He has been our to-go person for the discussion of multiple low-grade gliomas. I'm sorry, Dr. Michael, for the interruption, but we all know you very well, and you need no introduction. And your work and your definitely keen interest in neurofibromatosis, optic pathway gliomas, and providing a fantastic outcome to the low-grade glioma children is a matter of interest to all of us practicing neuro-oncology, and is a matter of interest for the research that is going on in neuro-oncology. Dr. Michael is the chief of the Neuro-Oncology Center and in the Neurofibromatosis program at the Children's Hospital of Philadelphia. And we're really blessed to have his presence today. Dr. Michael, the magical podium is all yours, and welcome once again.
Thank you for the kind introduction. Are you seeing the full slide? Is that projecting?
We are.
Fantastic. Okay. So what I want to talk today about is the challenge in the management of optic pathway gliomas in children with neurofibromatosis type 1. And these are my disclosures. I do some advisory board work and get some research support from some pharma companies, and I will be mentioning MEK inhibitors, which some of them have investments in. So just to remind you, neurofibromatosis type 1 is an autosomal dominant genetic disease, occurs in somewhere between 1 in 2,500 to 1 in 3,000 people worldwide. The protein product, so the gene is on chromosome 7, and the protein product neurofibromin is a classic tumor suppressor and a negative regulator of the oncogene RAS. Now, this is a very large gene. So interestingly, up to half of the cases of neurofibromatosis type 1 are first in family, and the rest are familial. And despite research gathering, very large series of genetic alterations in NF1, there's really very limited genotype-phenotype correlation, such that members of the same family with the same germline mutation can have very different manifestations. Now, less than 5 years ago, the criteria for neurofibromatosis type 1 was tweaked a little bit. And so I wanted to make sure that everyone was aware, and the changes are in red. So, the criteria still include having 6 or more cafe-au-lait macules, freckling in the skin folds, 2 or more neurofibromas or 1 plexiform, an optic pathway glioma. Now, separate or in addition to Lisch nodules, you could also have choroidal abnormalities, which are these bright patchy nodules you can see using optical coherence tomography. Distinctive bony lesions, right, such as sphenoid wing dysplasia or tibial pseudoarthrosis. It used to be a first-degree family member with NF1. Now it's a parent with NF1. And that really was changed because of the concern of the geneticists that people would miss congenital mismatch repair syndrome. And then we added an eighth, which is a heterozygous pathogenic NF variant. And so now instead of 2 of 7, you need 2 of these 8 criteria to make the diagnosis of neurofibromatosis type 1. But remember, those are only the diagnostic criteria. This is a multi-system disease, that has bony complications, increased risk of seizures, vascular complications, both in the CNS and elsewhere, cognitive issues, autism, etc. And so this really requires a host of medical professionals to take care of these patients. Now, my interest as an oncologist and as a neuro-oncologist in neurofibromatosis type 1 is that it is one of the most common tumor predisposition syndromes. And the tumors they're most likely to get, right, are CNS gliomas and tumors of the peripheral nerves. But there's an increased risk of malignancy of all types. The most feared is the malignant peripheral nerve sheath tumor with an 8 to 13% lifetime incidence. Most commonly, we're seeing low-grade gliomas, but high-grade gliomas happen too. And then I've listed a bunch of the tumors that are particularly high incidence in NF1 compared to the non-NF1 population, including JMML, rhabdomyosarcoma, pheochromocytoma, gastrointestinal stromal tumor, and breast cancer. And so how do tumors form in NF1? And we sort of have to start with looking at the pathways, right? So the protein product of the NF1 gene, neurofibromin, right, is basically accelerates the conversion of active GTP-bound RAS to inactive GDP-bound RAS. So when you lose the second copy of neurofibromin, right, you now have unregulated RAS signaling. And so you have increased signaling down RAS effector pathways. And that is what prompts tumor formation and progression. And we'll come back to this pathway later on as we start talking about treatments. So globally, when we think about low-grade gliomas in children with neurofibromatosis type 1, about 20% of children are going to develop a low-grade glioma. And if you look at this cartoon here on the right from an older publication, the majority of those are in the optic pathway. The second most common location is the brainstem, but you can see a smattering of these elsewhere. Now, historically, most of these tumors haven't been biopsied. And the majority that were biopsied have been grade 1 pilocytic astrocytomas that were presumed to be NF1 minus tumors. In the non-optic pathway glioma location, right, that you can see that this retrospective study we did with St. Louis and Chicago showed that more than half of them were asymptomatic. We took a deeper dive into the brainstem because that's where the highest location out of the optic pathway was, and only about 1/3 needed tumor-directed therapy. And you're going to see this as a theme in the management of optic pathway gliomas and low-grade gliomas in NF1. The bigger challenge isn't trying to figure out how to treat. It's trying to figure out who actually needs treatment. For the ones in the optic pathway, the majority are diagnosed before age 6. And once again, half or more are indolent with minimal tumor progression. Now, I mentioned that these are rarely biopsied. And so, once again, these were presumed to be NF1 minus pilocytic astrocytomas. So, a few years ago, we put together a series of 70 low-grade glioma specimens from 70 children with NF1 from around the world. And it was hard to find this many because, like I said, they don't go to the OR. And fortunately, we managed to get clinical annotation on 48 of them. So what did we find? Well, first, we found that a surprising number had some unexpected findings. Either they were not pilocytic by methylation, or they harbored an additional non-NF1 mutation, meaning they were not simply NF1 minus minus, they were NF1 minus minus plus something else, or they were NF1 plus minus plus something else. Okay, so however, and then from the clinical features, we discovered that tumors arising in the optic pathway were unlikely to have an unexpected finding. So that has us sort of rethinking, should more of these patients need biopsy or not? Now, you may look here and say, oh my gosh, about 1/5 of the tumors had an unexpected finding. But I would caution you not to overinterpret this. This is 1/5 of tumors that someone decided needed to go to the OR, of a group of patients who for years and years and years, no one sent to the OR. And in fact, if we extrapolate to the Children's Hospital of Philadelphia data to all NF1 children diagnosed with a low-grade glioma, that percentage would drop to less than 2%, because most of these tumors aren't treated. Most of these tumors, don't have any intervention at all. So it's actually a much smaller number. So how do we think about this? So globally, what I would say, given the overall low occurrence of finding a non-NF1 mutation or a non-pilocytic astrocytoma, routine clinical biopsy of a typically appearing low-grade glioma in a patient with NF1 is not indicated. And in particular, for those with tumors of the optic pathway or hypothalamus, the yield of finding an actionable mutation was quite low, and approached 0%. It wasn't zero, but quite low. We would consider biopsy of a non-optic pathway location tumor that's refractory to conventional treatment, has some sort of concerning MR features. It's growing rapidly, there's evidence of peritumoral edema, or there's an acute development of neurological signs or symptoms. So for the rest of the talk, I'm going to shift just to talk about the optic pathway gliomas. Now, fortunately, these tumors are rarely life-threatening. They tend to be vision-threatening, or they can cause disfiguring proptosis or hormone changes. And they're not your typical tumors, right? The natural history is unpredictable. As I mentioned before, half or more are indolent with minimal tumor progression. When they do grow, progression tends to be slow. And while extremely rare, you can see spontaneous regression without any therapeutic treatment. So how do we monitor patients with NF1 without a known optic pathway glioma, right? So I mentioned 15 to 20% will develop an optic pathway glioma. Principally, we do this with eye exams, right? We do eye exams in children less than 8 yearly. Once they're over 8, every 2 years until they're 18. At our institution, we only do an MRI if a concern is identified on the eye exam, or if we can't get a reliable visual acuity. So what does that mean? We'll talk more about this. If they come in and our ophthalmologist can't get a quantitative acuity, right? Because the kid's not cooperative and all they can get, let's say, is fix and follow. That's not good enough, right? You fix and follow at 20/20 or 6/6, and you fix and follow at 2200 or 6/60. That's 10 lines of vision loss. In addition, if you decide to get an MRI in a child with NF1, you should get the brain with thin cuts through the orbit so you get the detail you need. So on an eye exam, what are sort of signs and symptoms that would suggest that you should get an MRI scan, right? Poor visual acuity, drop in visual fields, proptosis, squint or strabismus, the optic disc being pale or edematous, or nystagmus. Anything like that should say, maybe I should be getting an MRI. So here's our challenge, right? I mentioned to you before, no more than 20 patients with NF1 will develop an optic pathway um, uh, glioma, right? So, and of those 20, no more than half are going to have vision loss and need treatment. And we certainly want to optimize the outcomes for this group. But equally important, the other half are never going to have a problem. We don't want to unnecessarily expose them to tumor-directed therapy. And if there's anything I can leave you with in the management of this class of tumors, is you need to find a good ophthalmologist to partner with, because the eye exam is crucial here. The goal of management is, once again, has to do with vision, right? They're rarely life-threatening. The goal is to reduce the risk of permanently clinically significant vision loss. And we know that what's happening with the tumor does not necessarily correlate with what's happening with the vision, meaning tumor can get larger, vision stable, vision improved, tumor could shrink while the vision gets worse. So what are the key elements of the ophthalmological exam? And I would say the most important is visual acuity. And quantitative measures are important, right? I already mentioned the challenges with the qualitative fix and follow. And you actually, if you invest in it, you can get quantitative measures in children as young as 6 months. How do you do that, right? So this shows you that over time, right, as kids develop, the kind of visual tests you can do change over time. So this classic Snellen chart that we all do as adults, ophthalmologists don't test kids in that usually until they're 6, right? When they're a little bit younger and they know their letters, you can do what's called HOTV matching. Even younger children, before they learn their letters, can do figure matching. And really young children, you can test visual acuity using these what are called teller acuity cards, where you see one side of the card has these stripes, the other side is blank. And if you know the distance from the card to the child, you can change the thickness of the stripes and make them successively thinner, such that the kid no longer sees the pattern. And we're basically taking advantage of the fact that a young child is going to want to look at the interesting pattern and not the blank side. And if you do this, and this is data from our natural history study we're doing, what we found so far is that 80% of children, you can actually get a quantitative acuity at the time of the diagnosis of their optic pathway glioma. Meanwhile, if you're trying to do a more advanced test like HOTV, only about 40% can. So it's really important. Invest, collaborate with a good ophthalmologist, try and get visual acuity. Now, the other important thing to understand is that vision develops over time, so that you don't have 20/20 or 6/6 visual acuity at birth. You don't develop that till almost 6 years of age. So you need to understand that there are age-based norms. And if you see a 3-year-old with an optic pathway glioma and their vision is 20/40 or 6/12, that's actual normal vision. It wouldn't be normal for a 6-year-old, but for a 3-year-old it is. And so it's really important to understand that. Other key elements of the ophthalmological exam, obviously, optic pathway gliomas can affect visual fields, although it can be very hard to get cooperation in a young child to get good visual field testing. We talked about the optic disc appearance. Pallor of the disc corresponds to atrophy of the optic nerve fibers. Swelling may represent recent progression, may not, but that usually resolves to pallor. And then lots of people are using what's called optical coherence tomography now. Now, this is a device that shines a light on the back of the eye that bounces back. And from this, you can get a readout to measure the retinal nerve fiber layer. which is the start of the visual pathway, right? And we know that damage anywhere along the visual pathway is reflected back in the thickness of that retinal nerve fiber layer. And so retinal nerve fiber layer thickness has been shown to be correlated with visual status, whether you've got good vision or not. But it's important to note that OCT itself doesn't replace actually getting a quantitative assessment of acuity and fields. How do we use it? We use it as one of many data points used to make a management decision. For example, if I can't get a visual acuity or I'm unsure of the reliability and the retinal nerve fiber thickness is normal, that likely supports that the vision is normal and may support observation. If I'm following a patient over time, and let's say the tumor has grown a little bit, and I'm unsure, I don't get a good vision, but the retinal nerve fiber layer is stable, that may support that the vision is stable, and thus I don't need to pull the trigger on treatment. Similarly, if I'm following a patient, the tumor is growing and I can't get a good visual acuity, but the retinal nerve fiber layer is dropping, that may be a cause for concern and a suggestion to consider treatment. So some of the key factors in thinking about pulling the trigger on treatment as opposed to observation is new vision loss over time, either acuity or fields, unreliable visual exam with other things changing, known poor vision in one eye to begin with, and then some features on the MRI, including tumor location and tumor growth, right? None of these in and of themselves are telling us everything, but these are the things we're looking at. Now, this is a more complicated way to look at it. This is a figure we put together for a publication a bunch of years back that is way more complicated in how to think about it. But it does look at tumor location here, right? We know that tumors, particularly behind the chiasm, those that have extended into the optic tracts and radiations, are more likely to need therapy. Obviously, growing tumors are more likely to need therapy, but they don't necessarily, because a tumor may grow on a scan and then stop grow or shrink on the next scan. Obviously, can you get a good visual acuity or not? So we broke this down into categories of who everyone sort of would agree needs treatment, those who would consider treatment, those where you need to not treat but watch closer, and those we would do nothing about. So I'm going to start at the two ends of this, which I think are generally agreed upon. And that is, if you are following a patient and they have a drop in visual acuity or fields over time, and in visual acuity, that's a 2-line drop, or what we call 0.2 logmar or more, that's an indication to treat. However, if you meet a patient for the first time at diagnosis and they may have a deficit in vision, they may or may not need treatment. That may be chronic and static, and not need treatment. At the other end of the spectrum, if you have a newly diagnosed patient with normal vision, or you're following a patient over time and the tumor stays stable and the vision stays stable, you don't treat that patient. In addition, precocious puberty or other hormone changes are not necessarily indications for chemo. Here's where it gets trickier, right? These other two categories, right? And this is meant to categorize, and the reference is down here if you want to find it. Things that you should be more worried may need treatment. And they include, if you already have complete or near complete vision loss in one eye, which is mean vision worse than 1 logmar or 20/200 or 6 out of over 60, that increases the importance of preserving vision in the good eye, right? Because you already have one non-functional eye. And so you may have a lower threshold to treat someone with a change. Similarly, if you have an eye that's at the functional threshold, it's not quite below functional vision, it increases the importance of preserving the vision in that eye. Meaning if you lose two more lines of vision, you may go from functional to non-functional. Similarly, in the setting of a reliable, stable vision, right, these are not primary indications for treatment. We don't treat for tumor progression in most cases with a reliable, stable vision, new eye findings. Okay. But once again, these things in the middle, less agreed upon in the community. All right. So that's how you think about treatment. How do you follow a patient with NF1 and a known optic pathway glioma that you're not treating? We do eye exams every 3 months for the first year, then every 6 months for 2 years and over 8, then yearly till 18. We don't do our MRIs as often. We do them every 3 months for the first year, then every 6 months for 2 years, then yearly, and then per clinical judgment. If we're treating a patient, we do an eye evaluation and MRI every 3 months on treatment, then every 3 months for the first year after, then every 6 months, then yearly, etc. All right, now let's go to treatment. Let's say we want to treat a patient. How are we treating? And so if you think about a low-grade glioma, not in the setting of NF1, but in the brain anywhere, right? This is the most common brain tumor of childhood. If you have a low-grade glioma in the cerebellum, right, you would take that out. Resection is cure for a pilocytic astrocytoma in the brain. However, remember, the goals of care here are to preserve vision. And so we're rarely doing surgery because to take the tumor out means to compromise vision further. There are some exceptions. This would be an exception. A unilateral optic nerve tumor with a blind eye that's causing painful or disfiguring proptosis. That may be a tumor you could do surgery for. What about radiation? Radiation works very well for low-grade gliomas. This is the 10-year progression-free survival of the old literature for optic pathway gliomas. But we know there's significant toxicity, right? You can have further loss of vision because you're radiating the optic apparatus. These tumors tend to be around the hypothalamic pituitary region. So you get hormone abnormalities. They tend to be near the circle of Willis. So you have an increased risk of stroke. And we already know that NF1 patients are already at risk of stroke, and it's magnified with radiation. They have an increased risk of second malignant neoplasms. I'll show you that data. And you're radiating what tends to be young people, includes the cortex, who very often already have cognitive issues. So just one piece of data on the second neoplasm risk in NF1. This was a publication from a few years ago where we showed that NF1 patients with a tumor are a 2.5 times increased risk of developing a second neoplasm and 3.5 times an increased risk of developing a second malignant neoplasm, right? If they're treated compared to survivors who didn't have NF1. Now, you might say, well, that's not that surprising. They have a tumor predisposition syndrome. But when you drill down, those treated with, if you look at a group of NF1 patients who were treated with radiation, right, versus untreated, there's almost a 3-fold higher risk of a second neoplasm. So we know that radiation causes second neoplasms, and it's more likely in NF1. So we're not using surgery. We tend not to use radiation. It's a therapy of last resort. Frontline therapy for years and years has been chemotherapy. The most common utilized regimen are carboplatin-based regimens based upon this Children's Oncology Group study in the NF population where the 5-year progression-free survival was 69%. About half of them had a partial response or more, which is 50% tumor shrinkage or more. If you drop that bar to 25% tumor shrinkage or more, a minor response, 2/3 respond. And some retrospective data that we looked into show that from the start to the end of therapy, about 1/3 of patients have a 2-line or more improvement in vision, 40% stable, and about 1/3 fail from a vision perspective. The Canadians have been very active using vinblastine on a metronomic schedule, albeit on a smaller based upon smaller data with reasonable progression-free survival, not as good of a response rate, unclear the visual outcomes because they had a very small series. For years, there was no real second line treatment beyond those because many of the other regimens you might choose to use for a low-grade glioma, like TPCV, right, thioguanine, procarbazine, CCNU, and vincristine, are avoided in NF1 because they have risk of developing or causing a secondary leukemia. And once again, tumor predisposition syndrome, we're trying to avoid things that can cause secondary cancers. Many people have looked at using bevacizumab, which can actually be helpful for visual recovery. But really, we've been very focused on molecularly targeted agents. And I'm just going to give you one example, which is the use of MEK inhibitors, right? Why are we using MEK inhibitors? I'll take you back to this NF1 pathway. You've got increased signaling down RAS effector pathways. And so we're just trying to block downstream of the increased RAS signaling. A lot of excitement for MEK inhibitors based upon this initial publication from the Pediatric Brain Tumor Consortium of 25 patients with recurrent low-grade gliomas in the setting of NF1, 40% response rate, a wonderful 2-year progression-free survival. The visual data, no one got worse, not a lot of improved vision up front, but they didn't do that prospectively. And everybody looked at this waterfall plot and this progression-free survival and got really excited, right? And so some people started using MEK inhibitors up front. So does that actually make sense? So here's the data, right? 40% PR rate, 2-year progression-free is 96%, and we had no idea what the 5-year progression-free survival was at that time point. Now, people, I think, were comparing this 2-year progression-free survival to this 5-year progression-free survival of carbovincristine. But if you now dig into the data, right, the response rate for carbovincristine is the same, the 2-year progression-free is the same, and now there's mature data on the MEK inhibitor. Carbovincristine seems like maybe it's doing better, right? And remember, this 2-year progression-free survival was still on therapy. It was 2 years of therapy, whereas carbovincristine was 15 months. So we still believe that carbovincristine right now is the frontline treatment for NF1-associated low-grade gliomas. But the MEK inhibitor data is exciting enough that the Children's Oncology Group has a phase 3 randomized study of upfront treatments comparing carbovincristine to selumetinib to see whether the outcomes from an MRI perspective are equivalent and to see which is superior for visual outcomes. Similarly, the Toronto group just finished a follow-up study of vinblastine looking at upfront comparing vinblastine to vinblastine plus bevacizumab. This was not NF1 specific, and we're waiting for the answers to that. So these are on the horizon. Once again, we start with carboplatin-based regimens and are now using MEK inhibitors as second line. So that's treatment. So let's step back. There's still a lot of unanswered questions, right? I already talked about this conundrum of who needs treatment. We have very little data on visual outcomes. The best data I showed you are all retrospective. We still have no idea what treatment regimen achieves the best visual outcomes, and we still don't know the true prognostic factors. So we've been involved with a large natural history study of newly diagnosed NF1 optic pathway gliomas. There are 22 centers involved from around the world. The goal is to enroll 500 patients at the time of their diagnosis of their optic pathway glioma. We now have over 300 enrolled, but this is the data when we had 281 and all the institutions involved. And this is just a preliminary snapshot, right? we are seeing that the median age of diagnosis of an NF1 optic pathway glioma is what you'd expect it to be, about 3 years. Most of them diagnosed by the age of 6. But there's this interesting tail here. And we'll be interested to understand, how do these kids at the tail do? We don't know yet. Thus far at diagnosis, right? You can see only about 12% go on to treatment at diagnosis. So most people at the time of diagnosis, there's not a reason to do treatment. Most are being observed. Thus far over time, once again, really preliminary data, right? Some of these patients are only on for a few months, but the blue dots are all the patients who started therapy at diagnosis. And there's another 29, these red dots, who started on observation and eventually needed treatment. Right now, if you're monitoring a patient, observation, the median time for a patient who needs treatment on the observation arm has been 9 months, but the range is up to 2 years. Once again, really preliminary data. So, what's the summary here, right? If you're going to take home anything from this, be thoughtful about who needs treatment. Most NF1 low-grade gliomas don't require treatment. The main goals of management should be preservation or improvement of function, which for the optic pathway gliomas is vision. Hopefully, I've left you with the huge importance of quantitative visual testing for optic pathway gliomas, and these new molecularly targeted therapies are promising. So I just want to end with a case, really briefly, if you think I have 2 more minutes. Will that work?
Definitely.
Just to sum it up. This is a real case of a patient of mine. In fact, I just saw this child yesterday. She's 15 now, actually, and she came for follow-up. But I first met her when she was 4. And someone had done a screening MRI of the brain at an outside hospital. Once again, we don't do those, but it revealed this optic pathway glioma, and they referred her to us for a second opinion. The mom had noticed that she had developed breast buds at age 4. And she came to us, and this was her eye exam, right? Her visual acuity was 20/30 in each eye. She had normal visual fields, no optic disc atrophy, and you can see this chiasm tumor that's enhancing. And the question to everybody, right, as you think about this case with what you've heard is, what would you do, right? Would you refer to a neurosurgeon to take that tumor out? Would you start carbovincristine? Would you start a MEK inhibitor, right, because of the visual deficit? Would you start it because of the precocious puberty, or would you observe? Okay. And we don't have time to do this in a get a response forum, but we observed the patient. And the point here is there was no visual dysfunction. 20/30 is normal at 4 years of age, right? So that's important to remember. The visual fields were normal. Was the tumor growing? We don't know. It was the first scan ever, right? So we didn't know that. We were concerned because the tumor was beyond the chiasm. And we know that the tumor was affecting hormone function. So what did we do? Well, we started Lupron to stop the puberty. We don't consider precocious puberty the reason to start tumor-directed therapy. And we followed the kid. And here is the baseline scan, and here's the follow-up scan 12 months later. No tumor-directed therapy, but this chiasm lesion, T2 hyperintense, right, has shrunk. The enhancement's gone away. And now we treated with Lupron. The kid was on Lupron for probably, 8 years. And then endocrine stopped the Lupron, and the kid went through puberty, and she has never been treated. And the point here is that, remember, normal acuity improves with age in young children. Large tumor size or even tumor growth doesn't necessarily correlate with function, and precocious puberty is not necessarily an indication to start therapy. So I'll end there just to acknowledge the team I work with at CHOP, as well as my key collaborators for the optic pathway glioma stuff. And I will stop there, and I'm happy to take any questions. Thank you.
Thank you so much, sir. That was really crisp. That was really amazing. I particularly adore the slides in which the logMAR reduction and the plan of treatment is specified. It's just so crystal clear to all the junior colleagues that where should we treat, where should we not treat, because that is the question that is always unanswered whenever an optic pathway glioma comes to the OPD. Also, congratulations to the amazing series of patients that you have collected. And even I am particularly interested in those presenting late, that how do they manifest, how do they present. So it would be really keen to read that work. And definitely, thank you so much for highlighting that particular point that vincristine carboplatin is the to go first line treatment, though the other treatments are promising and we are definitely awaiting results on the COG trials. But as of now, despite being so fancy drugs on the radar, the vincristine carboplatin always wins the battles. So definitely, thank you so much, sir. And my chat is already flooded with questions. If you permit, I'll ask.
Please.
So the questions are both OPG of NF and OPG non-NF related, sir.
Sure.
So, in the case of presentation, do you observe in your practice that the sporadic OPGs have more chiasmatic lesions and the NF1 OPGs have more optic nerve lesions?
I've not observed that in my practice. I don't, it's not clear to me that there's a difference. In fact, I think the difference I see is that the NF1 ones tend to be more complicated, bilateral nerve or nerve into chiasm and post chiasm. So I haven't seen that difference. There is a subtle difference in management in that while there are non-NF1 optic pathway gliomas that will sit there, my bar is much lower. They are way more likely to sort of declare themselves as needing therapy. So we definitely have a lower bar of treating the non-NF ones for sure.
So I remember one of my conversation with a neuro-oncologist, and he quoted one term, and the term was that NF1 gliomas are lethargic. So that thing is always, it
I
always
like
works.
that. I'm going
And
to steal
actually,
that.
definitely, sir. So given the fact that the pelomyxoid astrocytomas are more notorious for CSF dissemination than a general pilocytic astrocytoma, do you recommend a CSF baseline testing in such a low-grade glioma?
Say that again. Which low-grade gliomas does the question posit are more likely to spread?
So according to my junior, a pelomyxoid astrocytoma.
Pylomyxoid, yeah. So this is true. Pylomyxoid astrocytomas are more likely to spread. Hypothalamic astrocytomas are more likely to spread, although a lot of those are the most common location for pylomyxoid. So those don't really occur in NF1. Outside of NF1, that's a good point. So we don't routinely, in our pilocytic astrocytomas, do spine imaging, but we do for all of our non-NF1 hypothalamics or non-NF1 pylomyxoids. We don't do lumbar punctures, right? We don't see free-floating clumps of cells, but those are the ones that we do spine imaging on. It's a good point.
So when we are diagnosing in less than 1 year of age, the visual acuity testings have been defined, but it's definitely one topic of discussion always. So do you recommend that in less than 1 year of age, I mean, treat all OPGs?
No, to treat. So a couple things. We recommend convincing your ophthalmologist to invest in teleacuity cards. I'll tell you, it's very interesting. When we set up the natural history study, I think we thought we'd be lucky if we could get 60% of quantitative visual acuity at diagnosis. But we trained everybody and the ophthalmologists and the ophthalmology techs in how to do teleacuity cards. And we have over 80% we're getting acuity. So one is I do everything you can to get acuity. I would not empirically treat because most of those kids don't need treatment. But you have to start using your softer signs more. If they can't cooperate and you can't get acuity, you have to start looking, is the tumor growing? Is there new optic disc edema? What's happening with the OCTs? You're going to have to use your softer signs, but I wouldn't necessarily treat just because you don't know, but your bar is going to be lower in a growing tumor if you can't get a reliable acuity than it would be in a growing tumor with a reliable tumor. Once again, I'll watch a tumor grow through successive scans if I'm confident that the vision is normal, because I know it will not be inexorable growth.
So I really admire the fact that you're not doing routine MRI screening unless some vision signs crop in. That I'm really already impressed and a
Vision
fan of
signs are unreliable acuity. That's the key here, right? Yes, if we get acuity in an 8-month-old and they have nothing else, and we get quantitative acuity, we're not scanning. We're not. Remember, most of the world doesn't scan anybody with NF. They completely rely on the eye exam. A smaller percentage of the world does screening MRI scans. We've sort of taken out a middle ground here, right? To me, if you've got a normal eye exam, you have to prove that you've got normal acuity in both eyes, which can be hard to get. And so that's how we've balanced this between who to scan and who not to scan.
So you do visual acuity screening as well as OCT in all cases, sir?
We don't get OCT in everybody. There's that portable device you can do, but that's more research. So it's very hard to get OCT in the young kids, but we do acuity screening in everybody. We do those teller acuity cards in everybody. And like I said, in some 6-month-olds, you get an acuity, right? Sometimes you can't get a quantitative acuity till they're 2 because they're just that, they're just that uncooperative. But you'd be surprised at what you can get if you invest in doing it.
Definitely. So one of my colleagues is mentioning an unfortunate case that they came through in which there was optic pathway glioma in one eye and a glaucoma in the other eye up front because of NF. So they preferred treating that kid. So they wanted to know your take on this.
I guess it depends upon the glaucoma and what was going on, and what the vision in that eye was. I would treat the glaucoma, right? The glaucoma sounds like unrelated to the optic pathway glioma. I treat the glaucoma. Now, if you told me the vision in the eye with the glaucoma was, already at 1 logmar, i.e. non-functional vision, yeah, I might err on treating the optic pathway glioma. But if you told me the vision in that eye was, 0.2, 0.4 logmar, I'd probably watch and see whether the optic pathway glioma was declaring itself or not. You can't cookie cut it, right? You've got to think in terms of everything that's going on.
Too much things happening together, agreed. So do you clinically screen optic pathway glioma for NF at diagnosis, or do you do a NGS-wise screen in all patients of OPG?
Sorry, do I understand correctly? Are you talking about a population just of OPG kids and I don't know that they have NF1? What do I do?
Yes. So
It
upfront
depends.
coming to your clinic and you screening for NF per NGS.
I'm screening for NF with a physical exam to start with, and I'll look at the MRI scan. So if I look at this kid and he's got capital A macules, let's say it's a young baby with 4 capital A macules and a large head and some T2 signal abnormalities, I say they have NF1. I don't need a genetic test to know. If they're older, let's say they're 5 or 6 and they have no signs of NF1, not a capital A macular or not, I'm like, that kid doesn't have NF1. if it's the in-between kids. Like some of them are just obvious, and some of them, a young kid, maybe one caveolé macule, maybe I'm not sure. Those are the kids I would do germline testing in, but I don't know that you have to do germline testing in everyone. On the flip side, in our non-NF1 kids, we don't do a lot of empiric treatment. We'll empirically treat a classic optic nerve only glioma because to biopsy that tumor will likely sacrifice vision. But if you've got a chiasmatic tumor and you don't have NF1, we're likely sending you for a biopsy because we think our neurosurgeons usually can get a piece of those. Usually they're big enough they can get a piece. They're not into the chiasm. We want to know the molecular profile. So we want to
Yes.
know for sure it's a pilocytic.
Yeah, and actually, I agree with that approach because even we do a clinical case-to-case based decision based for NF. So
Yeah.
when we talk about surgery in a case of optic pathway glioma, do you most of the time practice a no surgery approach, or you decide on a case-to-case basis, let's say a exophatic mass or a suprasellar or mass with hydrocephalus?
Yeah. So in the NF1 population, it's almost never, right? Unless they have a big midline lesion causing mass effect, or that case of a isolated optic nerve glioma, proptotic eye, blind already. In the non-NF1, we are biopsying pretty much all but the optic nerve only ones. And we're never trying to take the whole thing out in a big midline chiasmatic. But if you have a big midline chiasmatic and the ventricles have blown up, sometimes our neurosurgeons like to take advantage of going in from above because the vents are big, debulking the part of the tumor that's in the ventricles away from the chiasm. I will warn you that we've had kids with normal vision that happens. Then there's and they do an endoscopic third ventriculostomy and things shift. And just by things shifting, the kids come out of the OR with some vision loss. There are some dangers, but those are the kids that we're most likely to debulk. I find a lot. The other thing we have to do is sometimes our surgeons need to go in to drain a pesky or cyst or fenestrate a cyst in a solid cystic pilocytic mass.
Definitely.
Yeah,
So
those are really tough cases.
yeah, definitely. We in some cases there are like they present with a hydrocephalus, and then we always ask the neurosurgeon. It's your take. Do you think
Yeah.
you can do a smooth sway here? Do you think you'll come out without damage? Then it's your take first, definitely. When we talk about treatment, sir, what is your take on carboplatin hypersensitivity? How often do you observe it?
So we have a publication on this. First author is Shah, first initial A, from a few years back. It's pretty common in the 20% range. At our institution, we are pretty aggressive about desensitizing. We have a desensitization protocol, particularly if it's just grade 1, grade 2. So when we have a hypersensitivity reaction, we usually try and take a break for a few weeks, and then we start. We extend the infusion from 1 hour to 2 hours, and we pre-med. If we have a significant reaction that we need to do desensitization, then they have this whole protocol every time they come in that we do. We've been fairly successful at getting kids through. But once again, if they had a grade 3 or grade 4 reaction, they're more likely to have another serious reaction. If they have a grade 1 or 2 reaction, we're pretty aggressive, particularly if we've had a tumor response or a vision response, and we know that carbo's working. I will say that we're probably outliers in how aggressive we are about desensitizing.
So
I can try and refer you to that paper while we're talking. I'll see if I can find it on PubMed.
Oh, definitely. I would definitely take a read into it and pass it on to my colleagues as well, because we are particularly, I won't say it's a LMIC thing, but we are particularly scared in re-challenging carboplatin once we have had the like a grade 3 reaction. And
Yeah, and I will say when we first started doing desensitization, we did it. I dropped it into I found it pretty quickly and dropped it into the chat. When we first started doing desensitization, we would do the first two in the ICU. We just do it in our day hospital. We've been doing it for years, but you have to have nurses who are on top of it, etc. But yeah.
and in the face of carboplatin hypersensitivity, do you go to vinblastine monotherapy? And do you think that's gonna
This in this day and age, in an NF1 kid, I'm more likely to use a MEK inhibitor as second line. The other thing I would say about MEK inhibitors, this is not based upon published data, although people are looking into this. There's a big concern in the community that so we tend to, when we use a MEK inhibitor second line, we tend to treat for about 2 years. There's a big concern in the community that a percentage of patients, when you stop a MEK inhibitor cold turkey, will have a rebound growth of that tumor. And I've seen it. I've seen a kid, the tumor back to the original size in less than 2 weeks, present with stroke-like symptoms. So we have gotten to weaning MEK inhibitors over 3 to 6 months when we decide to stop them for something other than toxicity. Huge caution. That is not based upon literature. That is not a standard of care. We need more data, but many people are doing this because of this worry. And I don't know what percentage, but there is this group of patients where I think, who knows what's happening? You're blocking the pathway so hard, maybe you're getting upregulation of receptors, and as soon as you release that hold, you get extra signaling down that pathway and the tumor explodes. I don't know, but we have a worry about it at CHOP.
So that's again a worrisome thing, which becomes when we don't have access to the drug, and it's like we can never tell the family till when we are going to do it. So that gives no
Right.
promising result to the family.
Right.
Yeah,
And if we don't have MEK inhibitors, just so you know, we use vinblastine as second line for us.
And do you like second line as in you combine with the BRAF, or you take it like BRAF monotherapy?
No. So if we can't get access, we do MEK inhibitor monotherapy. And if we don't have, like before we had MEK inhibitors, our second line was vinblastine.
And obviously, it's always a known thing with MEK inhibitor that they are a double-edged sword when it comes to macula, because they are notorious for causing macular edema, retinal breaks, at least theoretically. So, and it's also theoretically mentioned that we should have a dilated ophthalmic exam for them every 3 months whenever they are on MEK inhibitors. So,
Yeah.
what's your take on that, sir?
So as a non-ophthalmologist, but one who does some eye research, there will be a publication coming out soon on ophthalmologic complications of MEK inhibitors. So the reality of it is, in children, there's been very few issues of eye toxicity. Don't get me wrong, you need to follow patients. But there's been very few real ocular toxicities, is the first thing. The second is, do I think you need a dilated exam every time? No, I don't. I think you need a ophthalmological exam with an acuity and fields and a look at the discs, but you could look without that. Some people have gotten really fascinated with OCT. If you monitor patients with OCT, you will see some macular changes on OCT. We don't stop treatment for those. I've never seen those turn into an acuity issue. And when you stop the MEK inhibitor, they've gotten better. People get really concerned. I care more about clinical things. If I have a vision change or something, I care more. So yes, you need to monitor patients, but I think the risk is pretty low.
It's always the difference between the theoretical thing and the clinical practice. So I'm sure you have a huge number of patients on MEK inhibitors. So,
Yeah.
and what is your experience on PDL1 blockade in low-grade glioma, sir?
I've never done it for low-grade gliomas. You know, they're not, certainly not hypermutant tumors. It's not something I've done. I mean, and so I'm not aware of the data. There's so many other things to do. Yeah.
And talking about the long-term follow-up, in NF1, there's always a theoretical mention of 18 years. But in a non-NF1, how long do you monitor a post-treatment OPG?
Oof. That's a great question. I'm usually monitoring them, you know, I'm every 6 months, every 3 months for a year, every 6 months for 2 years, and probably yearly for about 5 or 6 years, and every 2 years till about 10 years out. My ophthalmologist wants to monitor them with an eye exam until they're 18. Sometimes once they're 10 years out from a scan, I may say to a family, I don't have any data anymore to inform you. You know, if I had a tumor and I was still a child, I'd want to scan intermittently every 3 to 5 years. I don't think we have data to answer that question. That's a tough one. I think it's a dialogue with the patient and the family about what makes them comfortable.
So someday we do a collaborative study and then see how long we have to monitor them.
That'd be
And
great.
And in non-NF1 optic pathway gliomas, it's always notoriously mentioned that avoid radiation because of a bystander effect of moya disease, a bystander effect of vasculopathy will be seen more commonly. So I have
More
personally.
commonly in the NF1 ones, not the non-NF ones. Yeah, the NF ones, absolutely.
So have you seen that, sir, very frequently in a radiation
We don't,
challenge?
we do in the NF1 ones.
Yes, sir.
Well, we do everything we can to not radiate any childhood low-grade glioma. But yes, I have seen it in NF1, and the second malignancy paper I was involved with, the vascular paper comes from Nikki Ulrich and others. It absolutely increased risk of vascular disease. I can't recall the last time we radiated a low-grade glioma in an NF1 patient. And I can barely, on one hand, the number of times we radiate a non-NF1 low-grade glioma patient. There are just so many choices: carboplatin, vinblastine, a MEK inhibitor, a BRAF inhibitor, depending upon what they have, TPCV, temozolomide, bevacizumab, cisplatin etoposide. Like, there's a clinical trial. There's a lenalidomide. There's a lot of it doesn't mean we haven't done it, but they got to be a teenager. We got to have no other choices. Yeah, we're pretty hesitant.
Well, that's it, sir. That brings me to the end of my lots of questions. And thank you so much for being so patient in answering so well to all of these. It was an amazing session, sir. And thank you so much once again for discussing this very important topic. And really, and me and my people from India, they were really blessed to have you as our chair today. And thank you so much once again.
It's been a pleasure. Thank you so much for the invitation. So have a great evening.
Have a great day, sir.
Bye.